ভালো আছো?
It is a privilege for me to welcome you on behalf of Sun Pharmaceutical Bangladesh Limited for joining live webinar on FAST eSPACE Endoscopy Masterclass Session 7. SPACE is the culmination of an endeavor to integrate evidence-based medicine with clinical practice primarily in the field of hepatology. With most learning points illustrated from the point of view of day-to-day practice, this program promises to be a highly interactive and practice-oriented event. Endoscopy Masterclass is an initiative which is planned to arrange with the objective to help our hepatology fraternity for improving their expertise in the field of therapeutic endoscopy procedure. This program is organized by Sun Pharma in association with Asian Institute of Gastroenterology and Forum for the Study of the Liver and BSMNU Hepatology Alumni Association, Bangladesh. I'd like to thank you all for all your hard work and support during these difficult times. Your humility, kindness, and strength are greatly appreciated. Sun Pharma successfully conducting different academic initiatives with view of disseminate latest scientific happenings in the medical fraternity globally. As a meaningful player in healthcare segment of Bangladesh, we have always valued the strong commitment and responsibility to share latest scientific information and knowledge available to us. Reaching people, touching lives based on innovation has been the direction of our journey since inception. It is our great privilege to have Dr. Nitin Jagtap, consultant gastroenterologist, AIG Hospital, Hyderabad, India, and Dr. Anand V. Kulkarni, consultant hepatology and liver transplantation, AIG Hospital, Hyderabad, India, for being today's speaker. I especially thank Professor Dr. Salimur Rahman, former professor, Department of the Hepatology, Bangabandhu Sheikh Mujib Medical University, and Professor Dr. Chittaranjan Debla, Principal and Head of the Department, Hepatology, Maiman Singh Medical College and Hospital, Maiman Singh, Bangladesh, as well as Dr. Fazal Karim, Associate Professor and Head of the Department, Hepatology, Sir Salimullah Medical College and Medford Hospital, Dhaka, Bangladesh, for accepting our request for being today's program panelist. I also thank to Dr. Prabhat Kumar Poddar, Associate Professor, Department of Hepatology, Sir Salimullah Medical College and Medford Hospital, Dhaka, Bangladesh, and Dr. Ahmed Lutful Mumin, Assistant Professor, Department of Hepatology, Purvitola General Hospital, Dhaka, Bangladesh, who will be with us and moderating the entire session. Now I invite Professor Dr. Salimur Rahman for next proceedings. Sir, please.
Thank you very much for inviting me to give the welcome speech. It is my great pleasure and privilege as President Association for the Study of Liver Disease Bangladesh to give this speech. I hope that this very important meeting will be a very successful one and will be beneficial for all young hepatologists, gastroenterologists, and other internists who are involved in this field. I also thank the Sun Pharma for an Asian Institute of Gastroenterology and especially the speakers for giving their valuable time so that the young hepatologists and gastroenterologists involved in this field can be beneficial from their excellent deliberation. And I hope this webinar and a great success. Thank you all for your patience hearing. Thank you.
Okay. Welcome to you all to this webinar. Today we have two speakers. First one is Dr. Nitin Jagtap, and he spoke on endoscopic bariatric and metabolic therapy in MFLD evidence base. And now I shortly introduce Mr. Nitin Jagtap. His work is MD and DNB. He is a consultant and Department of Gastroenterology and Hepatology, Asian Institute of Gastroenterology, Hyderabad. Dr. Nitin Jagtap has won different awards and grants. In 2017, he won the Best Award of First World Congress of Gastroenterology and 2017 March and received travel grant first Korean Digestive Week, Seoul, Korea, and December 2017 he won the Best Abstract Award
disconnected
of
pancreatic
the
duct.
Gastroenterology. In 2018 April, and selected for poster of ESG Day,
After 4
Budapest,
weeks,
Hungary,
maybe
and July
replacement of the
2018
plastic
he
is
is
not
selected for
necessary. That's all.
Young Leaders Academy Program.
Thank you,
for
Jangir.
Melbourne,
Thank you,
held
Sandeep.
jointly in
We
Melbourne
want
University.
master endoscopist himself now. Actually, we'll have a clinical details by Anirudh.
Trained the trainer and by Indian Society of Gastroenterology. He is reputed and gastroenterologist and hepatologist. He is a member of many professional societies, American Society of Gastroenterology, Association of Bariatric Endoscopy, European Society of Endoscopic Surgery, and Indian Society of Gastroenterology. He is a member of Indian National Association for Study of the Liver. He contributed many books and like 4 books. He contributed 4 chapters in gastroenterology and hepatology, endoscopic hepatic disease, and endoscopic palliation in metabolic disease. He contributed, he has many journal and reported publications in national international journal. He has 16 publications in national and international journals. Now I invite Dr. Nitin Jagtap for deliver his speech. Mr. Nitin Jagtap, please.
Thank you, Doctor, for this kind invitation and introduction. Let me share my slides. Can you see my slides?
Yes, okay.
So today's topic is about non-alcoholic fatty liver disease and how we can treat it by metabolic and bariatric endoscopy. Outside, I would like to thank Dr. Reddy for giving me this opportunity to work in the field of bariatric and metabolic endoscopy. I also like to thank Association of the Study of Liver Disease Bangladesh for giving me this opportunity to talk about this topic, which is very close to my heart. And this is really a great pleasure when we are celebrating 100 years of Mujib, that's Mujib Barsho, and we are connecting to each other on these great occasions. So coming to this topic, we all know that NFLD is emerging and ongoing pandemic, and this is preceded by a pandemic of diabetes and what we have learned from it. So when the type 2 diabetes prevalence was increasing, at that time the type 1 diabetes was more prevalent, and a few decades ago insulin was discovered by Professor Banting and Best. So at that time, all people started treating type 2 diabetes as type 1 diabetes, thinking that giving insulin will take care of type 2 diabetes also. And subsequent for around 5 to 6 decades, majority of drugs were concentrating on increasing the endogenous insulin resistance, despite of knowing that type 2 diabetes is the disease of insulin resistance. There is insulin, but we are still providing more insulin. And we are not thought about a metabolic part of liver disease that liver plays. The liver is a major metabolic hub which deals with metabolism of carbohydrate, lipids, intermediate metabolism, also protein metabolism. And we all know that what all we eat goes to the liver through the gut-brain axis and portal circulation. So do we consider managing diabetes, metabolic syndrome, and NFLD, this important gut and liver axis, and do we have anything to modulate it? So we all know and we all by heart this for our exams and our clinical practice. That's NFLD progress to inflammation. When we call this NASH, then it goes to fibrosis, cirrhosis, plus minus hepatocellular carcinoma, and we all know that the initial stage is reversible and then it's become irreversible. So what we actually need to understand is the level of treatment we can offer at what stage of the disease. So in medical graduation, we learn about levels of prevention. That's primary prevention, where you can stop the major illness, and in secondary prevention, where you can treat the illness, and in tertiary prevention, where you offer only a palliative care. So we don't want to do, because the initial stages, where if we treat, it's a curative treatment. If we stage in the latter stages, it's just a palliative treatment. So coming back to our main agenda today. So what is happening with your own country? So you all know that it's one of the fastest growing economy in the world, and is slowly shifting from agriculture based to the industrialized economy. As the GDP is growing, there is a changing in the lifestyle, and there is increase in the incidence of non-communicable diseases. At the same time, there is excellent work was being done in controlling hepatitis B and also in the population control. These are the few areas where Bangladesh has given an excellent results. So are we ready to have are we ready to deal with the upcoming problems? So coming to the NFLD, the initial papers which I found that there was a variable prevalence of NFLD in early 2014 reports, but subsequently in 2017 papers, the uh, prevalence of NFLD reaching up to 20%, and in diabetes is almost 50%. In this recent study, I could found that during one of the conference, which is commented that NFLD is the second most common cause of consultation at the liver clinics in Bangladesh. So this was the latest paper published in JGH, which talking about prevalence and the risk factors of NFLD in Bangladesh. Around 3,000 patients were screened, and the prevalence is up to 33% in the population. And the age, diabetes, elevated BMI, and married individuals are the independent risk factors for the NFLD, and the risk of NFLD is up to 44% in overweight people and more than 60% in those who are obese. So there is a large need to treat these patients at early stage, so that we don't have to treat them into the advanced stage. So this metabolic and bariatric endoscopy can treat NFLD at early stage and prevent uh, end organ damage in the liver and the advanced fibrosis. So I'll show you how this is done. So there are two types of bariatric or metabolic endoscopy, which either treat in the stomach or in the small bowel. So when we treat a stomach by endoscopically, either by intragastric balloon, transpyloric shuttle, or gastric reduction by plication, which is commonly known as endoscopic sleeve gastroplasty or aspiration therapy. These are the weight-dependent pathways where the benefit we get in the obesity or obesity-related comorbidities is due to weight loss. And when we deal with small bowel endotherapies, such as endoliner or duodenal mucosal resurfacing or magnetic anastomosis, we basically change the metabolism, and that leads to the improvement in obesity related comorbidities, rather than having only weight loss. The weight loss achieved by the small bowel endoscopic therapies are in the tune of 5 to 10%, whereas in the gastric it reaches up to 20 to 25%.
A little more tedious.
So,
I always use the
so this is the paper which is published by Mayo Group, in which they have analyzed 21 patients and in whom they put Orbera intragastric balloon for 6 months, and they have done liver biopsy pre-placement of intragastric balloon and at the time of removal. So they could achieve up to 11.7% of total body weight loss, and there in the biopsy there is median decrease of 3 points in non-alcoholic fatty liver activity score on the liver biopsy, and also there is a fibrosis improvement in 1.1 by 1.17 stages. But this total body weight loss is not correlated with the reduction in NAS score or fibrosis stage. So, despite of this much decrease, it was not correlating with total body weight loss. That means there are some part of gut liver axis which can be modulated or modified by this intragastric balloon therapy. So what happened in this study, you can see there steatosis improves at 6 months, ballooning improves at 6 months, inflammation improves at 6 months. However, when we see total NAS score and the fibrosis, there are few patients in which the fibrosis is worsened or it's static. So what I want to emphasize you can have a better results rather than treating them when there is a fibrosis is set in or there is a advanced fibrosis. So if you treat early, you will get a better results. So we are doing the similar study with adjustable intragastric balloon, which is called as eSPACE balloon, in the patients who are obese and having non-alcoholic fatty liver disease. We are also doing pre and post balloon therapy liver biopsy, which we are in the half of this trial. Study is ongoing. The good point for this intragastric balloon is that this balloon, a capacity of this balloon can be adjusted. It can be either increased if there is a static weight. There is no significant weight loss after 3 to 6 months, or on the weight reaches to the plateau, we can go inside, remove the catheter and put more saline so that the patient will again start losing more weight. Or other side, if the patient is not tolerating around 500 ml of saline infused in the balloon, we can go inside and reduce by 50 to 100 ml, and so that once the patient is tolerating the intragastric balloon, we can again increase the volume. So we have enrolled around 50% of these patients, and we are waiting for completion of this study. So coming to the endoscopic sleeve gastroplasty for obesity and NFLD, we are the first who published in the Journal of Digestive Endoscopy of our initial series in 2018, where we could find that around 20% total body weight loss is there in patients with obesity. So coming to the same point in NFLD, in obesity, in bariatric endoscopy, this is more than 100 patients, more than 2 years of follow-up with endoscopic sleeve gastroplasty using Apollo OST device, in which they have shown that NFLD fibrosis score, that is non-invasive score, is improvement at up to 2 years. What important thing they could have shown that insulin resistance is improved within 1 week from 6.7 to 3% in the terms of HOMA-IR within 1 week of the procedure, and this improvement continued up to 2 years. Also, there is 4-point reduction in hepatic steatosis index, 0.3% decrease in per year decrease in non-alcoholic fatty liver steatosis index. You can see in this slide, if there is early fibrosis, the patients who had no fibrosis or intermediate level of fibrosis in NFS score, these patients, after the number of patients who are having F0 or F2 fibrosis has increased after end of the follow-up at 2 years. However, those patients who had significant fibrosis, that's F3, F4 fibrosis, the percentage of decrease in these patients is not that much. So what I want to again emphasize, that if you are treating advanced fibrosis, then the results may not be adequate. We there is different platform to perform endoscopic sleeve gastroplasty, which is called uh, Indomina. This is developed in Belgium by our friend Vincent Huberty, and we are part of this multi-center study, which is around 15 center is Europe and one center in India. That's at AIG Hyderabad. This is little different than the ESG platform, than the Apollo Overstitch platform. It uses a single channel endoscope rather than using a double channel scope, which is required for endoscopic sleeve gastroplasty with Apollo Overstitch. And this device can be assembled within the stomach, so it avoids orifice limitation or the discarding of the need of device during the procedure. And due to this device added at the tip of the scope, and there is around 1.5 to 2 inch side in which the tissue can be grasped. So there large amount of chunk of tissue, gastric tissue, can be sutured using this device compared to the Apollo Overstitch device. So we have our initial experience in these patients who had hepatic steatosis index more than 36, of mean age of 44.63 and BMI more than 35. In these 26 patients, we could show that at the end of 12 months, there is significant improvement in ALT, hepatic steatosis index, non-alcoholic fatty liver score, FIB4, and also in the APRI. And this difference is static at 6 months, is progressive at 6 months and 12 months. So you can see in this same chart, so the ALT in each patient improves, hepatic steatosis improves, NFS score increases, and other hepatic steatosis and fibrosis scores also improve along with the weight reduction. We could show in this study that's 19.88% total body weight loss at 1 year after endoscopic sleeve gastroplasty using Apollo Overstitch. Thank you. This is from my side regarding endotherapy for non-alcoholic fatty liver diseases.
Okay. Thank you, Dr. Nitin Nakpa, for your very excellent delivery.
If there are any question, I am happy to take.
Yeah. Thank you, Nitin Nakpa, for your nice delivery and excellent presentation. And now, question answer.
Can I have a question?
Yes, yes. Dr. Fazul Karim, panel expert. Yes, if it's your question.
Dr. Nitin, which option would you prefer? And there are three options you have mentioned in your speech. Which one is the better one?
So for endoscopy in bariatric in NFLD and obese patient, we have two main options. That's intragastric balloon or endoscopic suturing. So we prefer intragastric balloon when there is a significant history of binge eating, and ESG when there is significantly associated comorbidities such as diabetes, NFLD, and hypertension.
In a NFLD patient, we first try for lifestyle and when
Yes.
to switch for bariatric and when to switch for medicines. Is there any?
So for non-alcoholic fatty liver disease without significant inflammation, there is no approved drugs. What we have is the main treatment is lifestyle modification. So we give a try of 6 months for lifestyle modification, and we try to target more than 7.5% weight loss in these 6 months. If there is no significant weight loss, then the bariatric endoscopy should be planned, at least for patients who are having obesity of type 1 or type 2, that's BMI less than 40 kg per meter square.
And regarding intragastric balloon, it is new, I think, in the bariatrics. This
Yes.
is what is. How long it you keep it? It is for
So
6 months or more.
So there are 2-3 types of balloons which are available in India. So one is Orbera balloon. So Orbera balloon, initially it was for 6 months, but now they come with balloon which can be kept for 1 year. And we are currently using SPATS adjustable balloon, which is kept for 1 year. So the beauty of this balloon, that if patient is intolerant to balloon, we can go inside, keep the balloon inside the stomach, just remove the catheter out by endoscopically, and reduce some amount of liquid from the balloon and put balloon back into the stomach. And if the patient is having a plateau in the weight, is not reducing adequate weight, you can just increase balloon volume by 50 to 100 ml in after 3 to 4 months. So we are more using a SPATS balloon rather than Orbera balloon. The Orbera balloon, which is a static balloon, we can't adjust the balloon, and there is 5 to 10% of patients who are intolerant to balloon. So these patients can be put onto the SPATS balloon, so that if they are intolerant or they are not feeling comfortable after balloon placement, you can just go inside and remove some of the liquid and make him comfortable. And once he is comfortable, we can subsequently increase the balloon volume so that he can achieve the standard endpoints.
Thank you.
I think anyone there's no more question, and next I will go on to the speaker, Dr. Anand V. Kulkarni, and he is working as consultant pathologist and liver transplantation, AIG Hyderabad, India. Dr. Anand V. Kulkarni is a hepatologist with a passion of treating patients with liver disease and experience of 4 years in this field. He completed his DM in Hepatology, Institute of Liver and Biliary Science. It is a premier institute of Asia, New Delhi, about liver care. He was awarded Best Fellow of American Association for the Study of the Liver Disease, ASLD, present his research work, and also awarded honorary member of Asia Pacific Association for the Study of Liver for winning the liver transplant quiz at International Upper Conference. He was also awarded the Academic Excellence Award and ILB. He was selected a core committee member of ASLDB and Portal Hypertension Education Group. He has 6 publications in his credit, and of these 3 are international and 3 national, one in Hepatology International and one BMG Journal. And Mr. Dr. Anand Karni has a member, and he is many members of this society and Indian International Society committee member of APASL and Special and International Institute of SIG, and honorary member of APASL, member of ASLDB and International Liver Transplant Unit, and member of EGL. Now may I request Dr. Anand V. Kulkarni for his presentation, and he will speak on refractory assist. Please, Dr. Anand V. Kulkarni.
Everyone, warm welcome, sir. It's a pleasure to be on the platform with you all. Today I will be speaking about the refractory ascites. Am I audible? I'm audible, right?
Yes, you are audible.
So this is a common complication which we see in our day-to-day practice. And that's why I chose this topic to discuss on ascites and refractory ascites. I do know that Bangladesh also has a good prevalence of hepatitis B and hepatitis C and cirrhosis. So ascites is a common topic for all of us. And I also welcome you all to India's best hospital for AIG Hospital, which was recently ranked as #1 according to the week's survey. And we welcome you all to AIG Hospital virtually. We also thank Dr. D.N. Reddy for giving this opportunity to share our thoughts on the topic of refractory ascites. The outline of the talk would be, we'll be just discussing about the cause of ascites in our settings, the definition of refractory ascites, the burden of the disease, the pathophysiology, the prognosis, and the management, current and future therapies. So this is an important study from Bangladesh which shows that liver is the major cause of ascites. It is the same holds true worldwide. It is same in India as well. It is same in Bangladesh as well. And more often we see this because of hepatitis B and hepatitis C, which is more prevalent in Asia Pacific countries. And we also know that most of these patients have HCC at presentation, HCC, hepatocellular carcinoma, because of the viral hepatitis. This is an important study which says that cirrhosis, yes, is the cause of ascites. So we come to the refractory ascites directly. What is refractory ascites? It is the International Ascites Club defines it as ascites that cannot be mobilized or the early recurrence of which cannot be satisfactorily prevented by medical therapy. There are two types. Either it is diuretic resistant, where we give a full dose of diuretics, even then there is no response of the patient. Or it can be diuretic intractable, where the patient develops diuretic-induced complications. And we then tend to stop as diuretics, and the patient is labeled as diuretic intractable refractory ascites. How to diagnose? Patient must be on intensive diuretic therapy. The intensive diuretic therapy says that spironolactone 400 mg and furosemide 160 mg. I differ with this definition because we don't see that we don't use such high doses of diuretics, and we often stop at probably 80 or 100 mg of furosemide and aldactone. So patient should be intensive diuretic therapy for at least 1 week on a salt-restricted diet. There is lack of response of it is defined as less than 0.8 kg weight loss in 4 days with aggregate sodium output less than of the intake. And early ascites recurrence within 4 weeks of the initial mobilization, or the patient develops some complications such as hepatic encephalopathy unexplained by other causes, or there is a development of renal impairment, hyponatremia, that is sodium less than 125, hypo or hyperkalemia, or incapacitating muscle cramp which are not being treated with albumin or baclofen. So basically, salt and drug compliant patient who has no complications such as bleeding, infection, or HCC or PVT, then we label them as refractory ascites. So diuretic tolerability, as they say, it is 160 and 400. We have recently shown that the patients of chronic liver failure who are started on diuretics, they hardly tolerate 40 mg of furosemide and 100 mg of aldactone. When those who are added on midodrine, the furosemide tolerability increases to 80 mg, and the aldactone tolerability increases to 200 mg. Revised manuscript, which is under review in JCH. So then we have diuretic intractable ascites or diuretic resistant ascites. This study, which was published in CGH, Clinical Gastroenterology Hepatology in 2006, says that most of our patients are intractable ascites. That is, they either develop renal failure or encephalopathy or dyselectrolytemia. We hardly see any resistant ascites patients. The prevalence of ascites per se in a cirrhotic is almost 5 to 8%. That is, that's a compensated cirrhotic progresses to decompensation around 5 to 8% annually. And of those, 10% of cirrhotic patients with ascites develop refractory ascites. And this refractory ascites is associated with a poor prognosis. It is transplant-free survival of less than 6 months per 6 months. It also impacts the ascites itself impacts the patient. It impacts the patient working quality and social life. It leads to frequent hospitalizations. It requires chronic treatment. It is a direct cause of acute kidney injury, hydrothorax, peritonitis, spontaneous peritonitis, and hyponatremia. And obviously, has a poor prognosis. So this graph, which was published in Gastro, says that the patients who have refractory ascites have poor prognosis, have poor outcome compared to response to ascites on the Kaplan-Meier curve, compared to those who were under LT for compensated cirrhosis, and compared to those who are under have compensated cirrhosis. So the refractory ascites, there's a worse survival when compared to others. Why do they develop refractory? Why do they become refractory to the therapy? Basic reason is as the liver cirrhosis progresses, there is increased sympathetic nervous system stimulation, which hampers the renal perfusion pressure. This is a sigmoid curve of Stuttlebar, which was published in our recent Liver International article as well, where we state that as the renal perfusion pressure increases, initially curve A is a patient who has no ascites, curve B is a patient who has diuretic sensitive ascites. With increasing renal perfusion pressure, there is increase in renal blood flow and there is increase in urine output. However, at curve C, that is diuretic resistant ascites and HRS, the curve is almost flattened. There is no response, even with rising sympathetic nervous stimulation, even with worsening liver disease, when with worsening RPP, there is no rise in RBF. So the patient develop become refractory to the treatment. So what they state is a patient who has cirrhosis but no ascites, the renal plasma flow 230 ml, he has a GFR of 83. In diuretic sensitive ascites, there is some rise in RPF, yes, but the GFR is maintained around 82. The patient develops resistant ascites, though there is a complete drastic fall in renal plasma flow as well as a significant decrease in the GFR. So this is the reason they become refractory to our therapy. They do not respond to any diuretics, and they tend to develop acute kidney injury very frequently. How do we manage? This was our step-up approach, which is also similar to our hydrothorax, which we published in Hepatology recently. What we said is the approved drugs have been colored as red. There is salt restriction, diuretics, large volume paracentesis with albumin, transjugular intrahepatic portosystemic shunt, and liver transplant. However, there is some evidence recently which has shown that albumin infusions, oral midodrine, terlipressin, alpha-pum, which is the upcoming study which has been published in JHAP, or the SGLT2 inhibitors which are used for diabetes, and tunnel catheters, they have some evidence to show that they can be useful in refractory ascites. I will discuss about the pros and cons of these in the next few slides. But obviously, the most important, what we use in our daily practice is salt, diuretics, midodrine, albumin, LVP, TIPS, and transplant. The first and best and the last treatment would be which is for our patients is transplant, but it is not affordable by everybody. So LVP is the first line of therapy. We tend to give albumin at a dose of 8 grams per liter of ascites removed. And we also avoid non-selective beta blockers in patients who develop refractory ascites as per a study by Lebrec in 2010, in which he states that the addition of non-selective beta blockers leads to worsening of renal dysfunction and liver failure. And there are no articles, there are no studies on the use of carbidazole in patients at present in decompensated cirrhosis, and hence it is to be avoided. Though LVP is the recommended first line of therapy, as whatever happens is post large volume paracentesis, there will be mechanical decompression of the vascular splanchnic vascular blood, which is to further decrease in the arterial filling, and the activation of the RAS, further worsening of rapid water and sodium retention, ascites, renal failure, dyslipidemia, and encephalopathy. This is called as paracentesis in the circulatory dysfunction, which is common after large volume paracentesis. So what we do next? We tend to start, we need to prognosticate the plan for TIPS, transjugular intrahepatic portosystemic shunt, which is a side-to-side shunt, which a stent is placed across the right portal vein and the hepatic veins directly to the intrahepatic structure. We avoid the get down on the resistance of the blood flow, and the shunt patency is maintained by an expandable metal stent which is placed in the intrahepatic tract. What happens post TIPS? Yes, there is decrease in the splanchnic blood volume, that is, there is decrease in the portal flow, there is increase in the systemic blood flow, thoracic blood volume increases. There is increase in the systemic circulation, systemic blood flow, almost 10 to 15% of these patients, the blood is diverted to the renal circulation, and the patients increase the diuresis. There is reduction in the ascites, there is improvement in the ascites control, there is reduction in the creatinine values. The mean response to TIPS in a refractory ascites is almost 50 to 76%. They respond very well to the TIPS therapy, provided the MELD is good. And it is also better survival, and it also is also better transplant-free survival at MELD score between 10 and 20. So preferable MELD is less than 18, who has no HE, no active infection, bilirubin less than 3 milligrams, and at age more than 70 is also relative contraindication, because none of the studies have included age more than 70 years. It's not that it's contraindicated. Basically, there are no studies which have included more than 70 years of patients. Next, what we do, we give them albumin infusions. This is also a 19 article published in Liver International. 20 grams twice weekly was given for 45 patients. This albumin reduction led to reduction in inpatient admission. They reduced the encephalopathy, ascites, SBP admissions, non-SBP infections as well. And the cumulative incidence of 24-month survival was better with patients who received albumin compared to those who did not. So this was based on the study on answer study, which was published in Lancet, which included 431 patients, and which showed that overall 18-month survival was much higher in patients who had received albumin compared to those who did not receive. Albumin infusion, long-term albumin infusion, led to reduction in 38% mortality in these cirrhosis patients. So midodrine is also one other drug which is now being used rampantly for refractory ascites and hydrothorax. It is alpha-1 agonist, which can improve the vasodilatation, increases the contrast the systemic arterial vasodilatation, increases the MAP, increases the renal blood flow, reduces the renal angiotensin activation system, and improves the ascites control. This was the figure which we published in Hepatology recently as a correspondence for hepatic hydrothorax. So there are 2 or 3 articles on randomized controlled trials on refractory ascites. This was a study from the postgraduate PGI, where there is 7.5 mg thrice daily of midodrine along with the standard medical therapy, and they showed that there is increase in the urinary volume, sodium, MAP at 1 month, and there was reduction in the plasma renin activity. So midodrine definitely controlled the ascites very well and improved the mortality as shown in this Kaplan-Meier curve. But hardly this study was only of 20 patients, 20 in each group. So even now the guidelines do not recommend midodrine as such. They just say there are anecdotal reports of midodrine improving the ascites control. This is a second study from the same group which said that addition of midodrine, the combination therapy of midodrine and tolvaptan improves the ascites control, but this is highly controversial because there are many studies which say that vaptans are not indicated, they are not recommended. The first study by Florence Wong in gut said that cetabaptan did not have any beneficial effect. It led to increase in MELD score, it led to increase in variceal bleed, and vaptans have in meta-analysis on APT has also shown that it has small beneficial effect on hyponatremia ascites and has no effect on mortality or complications of renal failure. So tolvaptan, on the other hand, it is also depletes the vitamin K dependent clotting factors and inhibits the platelet aggregation, which has the risk of variceal bleed, hematomas, ecchymosis. So vaptans definitely no for any cirrhotic who has child B or child C cirrhotic. Child C cirrhotic is a black box warning, obviously. Child B as well is not to be done. Then we planned a study on the early addition of midodrine. Why to wait till development of refractory ascites? We thought any patient of ACLF who presented with ascites or AKI, after resolution of AKI, we give them midodrine for around 1 month. We saw that there was reduction in the ascites, there was improvement in the ascites control, there was improvement in the hyponatremia, they improved the thyroid tolerability as well. This article is under revision in the journal. Then the next vasoconstrictor which is used now, but little difficult to use for refractory ascites because it requires intravenous infusion, is terlipressin. This is the figure which we have published recently, Liver International, it was invited review, where we have shown that terlipressin improves the renal perfusion pressure, decreases the renal arterial indices, and there is an increase in the renal water clearance. There is an increase in the hepatic venous portal gradient, HUPG. There is a reduction in nitric oxide levels. There is an improvement in the mean arterial pressure. Thereby, all this contributes to rise in the renal perfusion pressure and increased urinary output. This is our review, which has extensively been quoted and is now the number 3 article in Liver International. This article, they have shown that there are 2 articles on refractory ascites. One, the bilateral study of 26 patients of refractory ascites who were given terlipressin therapy. They improved with a dose of 0.5 to 1 mg the KOID for 3 weeks. They had significant improvement in the ascites control. Now, one more study which was published in the American Journal of Gastroenterology, the letter to editor. There was a study of 5 patients where they reported that ambulatory terlipressin therapy for 4 weeks improves the MAP, urinary output, and ascites control. It also led to improvement in the reduction AKI along with the control of the ascites. Next, what will come is the automated low flow pump system. It is the alpha pump. It is a battery operated pump which is kept subcutaneously. The catheters connect the peritoneum to the urinary bladder and it keeps on emptying in the urinary bladder. This is the first study published in Journal of Hepatology in which mean MELD score around 12.6, and most of them were child B and child C cirrhotics. What they showed is post-implantation, the number of paracentesis per month significantly reduced. The volume of paracentesis at each session also significantly reduced. However, this alpha pump was associated with 27% risk of SBP and 20% risk of urinary tract infections. So alpha pump now is being recommended only in the setting of research settings or in the patient who knows that there are some complications associated with it. Next, we come to long-term abdominal drains. This is the recent trial which was published in APT. This is a randomized controlled trial of 36 patients. 19 received only LVP and 17 others received only long-term abdominal drains. They are also on regular antibiotic therapies. LTADs, that is long-term abdominal drains, reduce the number of which hospital drains to almost zero. These patients only required almost zero number of patients required ascetic drains, while LVP patients required almost 4. It was significantly different. But the risk of LTAD, the long-term abdominal drains, is the cellulitis. It occurred in almost 41% of the patients compared to only 11% to underwent LVP. So cellulitis is a difficult complication. Once the patient of cirrhosis develops cellulitis, it usually have poor prognosis. So as of now, the guidelines recommend that it is a palliative care indicated for patients with malignant ascites or a patient of refractory ascites who has no liver transplant option. This is the recent drugs which are upcoming for the ascites, and the SGLT2, sodium glucose transport inhibitors, dapagliflozin, empagliflozin, and canagliflozin. They act at the proximal tubules, levodopa act at the distal tubules, thiazides act here, and this is the potassium diuretics. When we inhibit SGLT2, it increases the secretion of sodium and glucose in the urine, that is glycosuria and natriuresis, and it attenuates the renin secretion, that is, it inhibits the RAS system. So there is improvement in the glycemic control, there is improvement in the hyponatremia, there is reduction in the RAS activity. So this was actually based on this study which was published in European Heart Journal. This was for heart failure patients, in which there are patients, almost 7,000 patients were treated with empagliflozin, where there they said that empagliflozin reduced the number of patients requiring heart failure admissions, almost by 34%. So this was the basis of all this study which are coming up on cirrhosis. This is a case report which was published in Hepatology recently of 3 patients. One received empagliflozin, the other 2 received canagliflozin. They said that there is significant improvement in the weight and also in the ascites control. However, we contradicted this. We wrote a letter to editor in hepatology saying that the mechanism of action of diuretics and loop diuretics and SGLT2 inhibitors are same. Why did the SGLT2 inhibitors did not precipitate hyponatremia or hypovolemia or encephalopathy? Secondly, SGLT2 inhibitors are metabolized in the liver, so it needs more safety data before we recommend further. Take-home message: refractory ascites is a common occurrence in our day-to-day practice. It is associated with poor outcomes. Management includes vasoconstrictors with diuretics and albumin therapy. Obviously, interventional radiology is very much important. Tips provided the patient satisfies the criteria for tips. Liver transplant definitely remains the treatment of choice, and alpha pump and long-term abdominal drains need more data, and suitability or renal setting is still not known. The SGLT2 inhibitors, they have some promising data, but needs more evaluation. What we do and what is approachable in our setting: diuretics, add midodrine, albumin infusions if affordable, then plan for recurrent LVPs, translunar intrahepatic portal system and LT. Thank you. Any questions, sir?
Thank you, Dr. Anand V. Kulkarni, for his elaborate presentations, and he has nicely described the management of refractory ascites, and he covers all the aspects of like large volume paracentesis, tips, heme and albumin infusions, midodrine, and last of all, liver transplantation is the treatment of choice for treatment of refractory ascites. I think, is there any questions? The notes are boxing questions, and
So, sir, can I have questions?
panel of experts, Dr. Fazul Karim, ask question to Anand V. Kulkarni, please.
Thank you, Dr. Kulkarni, for a very nice and informative presentation. My question is, do you have any experience with toracimide? furosemide is available in our country, like furosemide.
Torsemide, the mechanism of action of torsemide and furosemide are same. We do use torsemide in patients who are little obese, who require higher doses of furosemide. So just add them the torsemide 20 mg or 40 mg accordingly as per their requirements. But we hardly up the direct dosage in these patients, whether it is torsemide or furosemide, we hardly go beyond 80 mg.
Okay, sir. The next is midodrine is not available in country. So I like to know how you monitor the dosing of the midodrine and how do you accelerate the dose.
So for midodrine, we tend to monitor the mean arterial pressure. We ask them to monitor the blood pressures regularly. If there's any rise in blood pressure by 15 mm, we tend to stop it. We target a map of around 75 to 80 mm. We don't go beyond that. And we also monitor the weight of the patient, which helps us to assess whether the patient is responding to therapy or not.
In our country, we do not usually practice large volume paracentesis because of the risk of renal impairment. And we do go for just albumin because patient cannot afford albumin more than 50 ml, that is 20 milligram.
Yes.
How to, do you have any suggestion regarding this and how to?
If the patient has simultaneous coagulopathy, 2 packets of plasma, fresh frozen plasma, it is much cheaper than albumin. If you can provide that at least once in 15 days or once in 3 weeks, it's also a suitable alternative for albumin. I don't say that albumin has no other this one, but definitely you can try with plasma therapy because it will improve this coagulopathy as well as provide some albumin to the patient. And it's same here as well because most of the patients cannot afford the long-term administration of albumin. They hardly take it for 4 or 6 weeks.
Yes, sir. This is really a problem.
Yes, sir.
Thank you.
Thank you very much.
Any other questions?
I think this is an example of how technology is changing everything. So we go to another room where we have Dr. Sandeep waiting for us.
If somebody was written, how do SGLT inhibitors work in refractory ascites? Can we use them without DM? So there is no evidence as such. There is only case report of 3 patients, which has been used in diabetes. Patients were given diabetes patients who had ascites, which are not getting controlled, had given SGLT2 inhibitors. As I showed previously, how do they work? They only work by increasing the natriuresis.
Compared to percent, US biopsy has one lower incidence of
I think we shall
thank you, Dr. Anand Kulkarni. Now today's 2 lectures of this session masterclass is over, and now we are going to AIG Hospital for live demonstration, and I hand over the mic to Dr. Ahmed Lutful Mobin to moderate this session.
Thank you and welcome to AIG virtually.
Okay, thank you very much.
Hello, this is Dr. Nitin from Asian Hospital.
Yeah, we're here.
So we are starting now live program and
it's actually a transparent liquid, the white core.
So we are demonstrating a US guided liver biopsy for this patient.
Okay.
Want to take another biopsy?
Yes, we want to take more because we want to have a complete evaluation because its diagnosis is not yet. So we'll take one more pass with wet suction technique.
Show that because.
Yes. So now you can see I have modified my technique. I flushed the needle with the saline and I attached a saline here, and this makes the channel filled with the saline, it's not air, so that the capillary action of the water is better and there is chance that we may get a better tissue. So again the technique is same. I first pass the stylet, I'll adjust here, I lock, of this site is so we are just loading wet section here. 2 ml of normal saline.
So
We have loaded in the
this is the
suction
patient who is young,
over the
35 years old, having recurrent
okay.
recurrent history of transaminitis, viral markers, and other etiological workup for liver disease is negative.
So now
So to evaluate further, we are
again Doppler here.
and endoscopy also not showing.
Select the best site. You can see my needle has gone inside. I'll take more passes. Suction on. Every time it has to be under dynamic. We have to see still. We have to see the Doppler flow. Process has to be very systematic in a fan technique that we target each time different area that the is.
Thank you, Jangir, for that excellent demonstration. Go on to the next room. Sandeep.
Thank you.
Case,
Thank you.
This is a 54-year-old male, known case of metastatic adenocarcinoma colon since April 2019 and is undergoing chemotherapy. Poor nutritional status. Now he presented to us with pain in abdomen associated with vomiting, abdominal distension, constipation, 5 days. They showed multiple air fluid levels. Notice this. It is showing a circumferential asymmetrical wall thickness of rectosigmoid and sigmoid colon with maximal wall thickness of around 2.4 cm, causing you proximal dilatation of bowel loop. Plan is to do a palliative colonic stem treatment. Over to Dr. Sandeep.
Thank you, Anurad. Good morning once again. As you heard the history, this patient has colonic cancer with widespread metastasis and he has recent colonic obstruction, and the plan is to place a metal stent inside. Do you have the endoscopic view there? Yeah. So this is a tumor there. This tumor starts at about 15 centimeters from the anal word, and beyond that it's very tight block. So I'm using a therapeutic upper GI endoscope, and I'm passing a cannula. Do you have the fluoro image also? Yes. Can you have the fluoro image on the screen? Yes. So, Srinivas, can you pass the wire? Yes, that's gone deep in. Okay. So what I'll do now is it's a double lumen cannula. I'll put some contrast inside to just estimate the length of the stricture. Although it looks quite short on the fluoroscopy because air column, please inject. Inject. Little more contrast. Inject. Okay, I think this is okay. So I'm using the air column also as my landmark. Contrast is right line. Okay. This is a Teramo wire which I had used, a hydrophilic wire. I'll exchange it with a stiff wire. Yeah, okay. Really. Yeah, okay. So we'll now change to a stiff wire and then place over the wire stent. Can you show the stent that we have decided to use? I think for this patient, it will be uncovered stent to prevent any migration. And the stent diameter is about 20 millimeter. This is a Taiwan stent, 14 centimeter long and 20 millimeter diameter. So I'm exchanging now, leaving the stiff guide wire inside. Yes.
How do you decide the length?
So the stents are available in 12 and 14 centimeter long. It has to be at least 3 or 4 centimeters extending on either direction of the stricture. So the stricture, actually we had a image which showed about 3 centimeter vertical length. So 4 centimeter on either side is 8 centimeters plus 3. So at least 11 centimeters stent should be ideal, because these stents will shorten with the passage of time, and to accommodate for that, we'll leave a longer length on either side. So this stenting can also be done as a stopgap measure in patients who are resectable. Here the patient is not resectable because of the advanced disease, but those who have a presentation as a colonic obstruction, and eventually, so we can avoid one surgery. So that's the major advantage of a colonic stent. Here this is palliative to prevent reoccurrence of colonic obstruction. I'm now passing this stent. Here comes and the fluoroscopy also. Patient is in left lateral position. So that should be the center. That's a center mark which has come. So we'll keep it close to the. Mohan?
Mohan, baby.
Raju, okay? Yeah, okay. Yes, please. So he's now deploying. Srinivas is pulling back the sheet. Stop. I'll pull back a little bit. So there's a central mark of the stent, which, yeah, that's one, which I'll try to locate on the center of the stricture. And that makes my either side equal. That prevents any migration in future. Just deploy. I'll keep it tucked here. I'll keep it close to the, stop. I'll keep it there, okay? Please go ahead now. Okay. So here comes the tip of the sheet, which is now about to overlap the center of the stent. Please deploy. Okay. The rest of the stent I can deploy in the scope as well. I think let's do that, because the central mark will help us in visualizing. Deploy. I'm deploying within the channel of the scope. Deployed? Yeah, okay. So now it's deployed, and I'll come back, pull back my scope, pushing the assembly out. So as soon as this gets deployed, the fecal matter will start coming from top. That's right. Yeah.
And I think this is some procedure which can be done very frequently. Actually, sure, our moderators in Sri Lanka and the audience would agree. Nicely
So now the fecal matter is coming out.
So you have to stand away from it. Any questions from the moderators before we switch the room? No, we are not able to hear you. Yeah. Yeah. Yeah, so there is the advantage of hot axios is it's a single system where you put in both the artery and the stent on the same system, and then you can actually deploy the stent. Axios stent is different from Nagi's stent because it's a lumen occluding. It's actually the lumen opposing stent. Both the lumens are opposed. Whereas the Nagi stent is non-lumen. But now we have hot Nagi stent. Exactly same principle. Using the hot Nagi, you don't have to use the steps of dilating, putting in a wire and all those things. You can directly use it as a needle. Using cutting current, you can directly push the stent down, the hot Nagi, and deploy it like the hot axis and hot Nagi are equivalent, except the stent itself. Nagi is a pipeline stent which is not causing opposing parts of the lumen. Yes, axial stent is if and opposes both flaps. Yeah.
Also can.
Yeah, usually the best stenting is done for left colon, like what Sandeep has shown you, because that's where the obstruction occurs. But even right colon can be stented, there's no problem, because we're doing with the colonoscopy. There are instances where right colonic growths. As long as the growth is a little away from the cecum, we can always stent because you must have movement there, put a stent further down. So the best stents are for left colon, but right colon and transverse colon can also be stent. Okay, I think we should go on. Sandeep, fantastic case. You can see the
Thank you, sir.
then very nicely. I think we should go on to the next case, another room, where we have patient for very new procedure.
Now we काम करते हैं.
We move on to next case. The case of 42-year-old male presented with history of recurrent overt obscure GI bleed requiring multiple blood transfusions. History of documented subacute intestinal obstruction for 6 months, and his investigation showed a raised inflammatory markers including raised ESR and CRP levels with high fecal calprotectin. Upper GI endoscopy and colonoscopy were unremarkable. CT enterography was done for further workup, which showed a circumferential bowel wall thickening with mucosal hyperenhancement noted for around 2.5 centimeter length in distal jejunum. Plan is to demonstrate power spiral enteroscopy. Over to Dr. Mohan.
Good afternoon, good morning, and welcome back to our endoscopy suite. And this is the ideal case for enteroscopy, not capsule endoscopy. And as you heard in the history, that patient has episodes of subacute intestinal obstruction and GI bleed. So this patient will not qualify for the capsule endoscopy because most of the time the capsule will get stuck. So deep enteroscopy is the best option for this patient to have not only assessment of the cause of the GI bleed, but also if there is a critical stricture, we can dilate that or take biopsies to ascertain the cause of the obstruction as well as GI bleed. So this enteroscopy can be done basically by either a balloon assisted enteroscopy, which is a method of push and pull enteroscopy. The disadvantage is that the scope is long, the therapeutic channel is not there, 2.8, the irrigation facility is not up to the mark. We have to buy dedicated accessories, longish accessories to do any therapeutic procedures, and very cumbersome, very very traumatic to the endoscopist. So we are looking for a scope which helps us to reduce this problem. Number one, by separate irrigation channel, which is there in this scope, which I'm going to tell you. The therapeutic channel is 3.2. The length of the scope is 165 as opposed to 200 centimeters for balloon-assisted enteroscopy, which enables us to do this procedure with routinely available accessories for the therapeutic purposes. This beauty of the scope lies in the self-propulsion, because now up till now, the overtube, we should understand that to negotiate a freely hanging structure like small intestine, we cannot do enteroscopy by a bare endoscope. We have to have an overtube. So overtube, this is the overtube which has got a spiral attached to that, which can rotate in a clockwise or an anti-clockwise fashion by just push of a pedal, like a brakes or accelerator in our car. The moment I am pushing forward movement, the spiral is moving in a clockwise fashion. So if it moves in clockwise, it propels the scope in forward direction. If I press the backward pedal, it moves in backward direction. So this spiral enteroscope, this overtube converts this spiral energy into the linear energy and helps in propulsion. So this scope has got many good features for it to be a very attractive option for doing the deep enteroscopy. The only problem is that this patient needs to be intubated because it needs some time to remove this scope, and in some improbable emergencies like desaturation, you may take some time, and that's why that vital seconds may be lost and we may do some damage. So patient is intubated, left lateral position. I have preemptively dilated the esophagus to 20 mm because this overtube is 3 centimeter wide. So now the first thing is I will insert the scope like a normal scope up till I feel a resistance. You can see now I'm in the esophagus, and I'll start the motor now. This is the motor. And I'll start the motor, and that will propel the scope. I'm not pushing. I'm just giving the direction to the scope, and this is self-propulsion. So we can see that it is self-propulsion and it's moving fast. Now it has stopped. Now I have to see why it has stopped. Because there is a mechanism, safety mechanism in this scope, that if the resistance goes beyond a certain prescribed limit, the machine stops because we don't have any tactile feedback in the scope. So this machine is having a tactile feedback. It gives to machine that if you encounter some resistance, you stop. That is a safety mechanism deep into the intestine. If you find any stricture or if you find a kink, and if you try to forcibly move the scope beyond certain level, you may cause perforation because you are not knowing whether there is a resistance or not because the machine is being propelled by a motor. So that is the safety mechanism. So I'm not able to go beyond this point. So what I will do is I'll do some extension at the neck of the patient, and my anesthesiologist will help. That makes this angle obtuse, the pharyngeal angle, and then you can see again I started going down. And now I'm traveling through the stomach, will reach to the pylorus. See that now I reach to the pylorus, and now what I'll do is I'll try to negotiate this duodenal angle. This is the most important. So you can see I am just going into the D2, but my problem here is to negotiate ligament of Treat. So as soon as I come into the duodenum, I switch off the CO2 and I drown myself in a water. Can you start the water? So I'll suck out all the air. That reduces the distension of the intestine. So whole deep enteroscopy works on a principle that if the intestines are collapsed, the overtube functions well because it grips the intestine well. But if it is beyond a certain limit, if it is distended, and you tend to put the finger on the air channel, the intestine keeps on distending, and the functionality of overtube reduces. And that's why your deep insertion sometimes is not possible. So you can see now there is no air and it's only under complete water. So now this is the most important step in enteroscopy, how to negotiate ligament of Treat. If you negotiate the ligament of Treat and you are in the proximal jejunum, you will swim across up till the cecum. So now this is a trial and error method. I am just reducing the loop into the stomach. Can you show the fluoro picture, please? So you can see if I am in the long loop position, in the scope is following the greater curve. So I'll reduce this like an ERCP scope. Now I am to the lesser curve, and there is less resistance. And you can see the tip of the scope is fighting to go across the ligament of Treat. And you can see the machine is getting stopped. How do you know machine is stopping or working? You have a gauge available on your screen on the left side that shows the green dots. And the more the number of green dots, more is the resistance. So if the resistance goes beyond the last dot, the machine stops. You can see now it has gone beyond the last dot and machine has stopped. So I pull back the scope, pull back the scope. Again, you can see the fluoroscopy, please. So this is how you negotiate. You You try to push with the greater curve, machine stops, you bring back. So this procedure takes some time and it's quite cumbersome. But once it is done, then you can go across very easily. But it may take some time, maybe 4 to 5 minutes, till you engage the ligament of treats and you've gone beyond. So I'm looking into the angle. This is the angle. I need to go beyond this till my scope engages the ligament of treats and I am in a comfortable position. You can see now it's now started flowing. So I'll just ask my assistant to fill it with water. Sometimes if I am in the corner, I'm not able to see. I take the liberty of starting the CO2 again for some time. Yes? Yeah. So we have published our data, and if you do a bidirectional enteroscopy, in 60% of the time you can do pan-enteroscopy. That means you can evaluate from whole and small intestine in 60% of the time. But that is not the clinical scenario. Clinical scenario is to reach to the diagnosis. Like if you are having a stricture or a capsule stuck, or you have some foreign body, you reach to that place and you stop. So clinically, you may not require to do pan-enteroscopy always, but most of the time, in 60% of the time, you can reach complete, you can do complete bowel examination.
So, Mohan, as you're doing this, we'll go to Zahir.
Yeah.
Come back to you. In fact, Zahir is doing the most complicated procedures that done in therapeutic and third space and remove tumors from third space. And he's of course again another expert in this area. So he's already reached this epithelial tube. Going to tell us what is this. Zahir, around.
Yeah. Hi, welcome back. I apologize that you had to wait for some time before you could come back. This tumor, I was asked the question that what could be the complications. It's not exactly a complication, but sometimes it can be really difficult to localize the tumor. And I'll tell you the reason why, because some of these tumors, they are completely covered by the muscle layer. And when you go inside the tunnel, it's very difficult to recognize the initial point of this tumor. Now, can you see this tumor here? So this is, and you'll agree with me that the initial size that was being described on EUS, that was 1.5 centimeter, this is way bigger than that. Can you see that? This is way bigger than, I believe this should come around 2.5 to 3 centimeter at least. So what I am doing right now is, you see, this is, we have isolated a bit of tumor and EUS assessment said that it was from the mucosal muscularis mucosa, but sometimes there is a big attachment to the muscle, and what was surprising for us was that this tumor was completely covered by the muscle layer, completely covered. So we are injecting, separating this tumor from the surrounding attachments, doing this submucosal dissection, and sometimes these procedures do take time, but then at the end, this is all being done using endoscopic technique. You can see the top of the tumor and you can see the muscularis attachment. See how the muscle is attached to the tumor. So leiomyomas, they can arise either from muscularis mucosa, that is the second layer, or they can arise from the fourth layer. My experience is they more commonly arise from the fourth layer, and whether this is a leiomyoma or just, I think if it is arising from fourth layer, histopathology will give us the final answer. What I am doing is cutting the attachment of this tumor from the surroundings. This is a bit more complicated than the POEM procedures, because here you have to be very precise in dissecting the tumor from the surroundings. Sometimes the localization of tumor is tricky. Like in this case, It took us some time before we could finally say that, okay, this is the tumor site, because look, it was completely covered by the muscle, as you can see here. If you have any questions, I'd like to
I think very nice demonstration, Zahir. I think complex but beautiful demonstration to actually how you're dissecting out the tumor, and I think soon you'll be taking it out and closing the opening like it was in poem that you closed. Now what we'll do, I think go to another room where Rakesh is ready with a more common garden type of case which you see in clinical practice before we come back again. So it's over to Rakesh.
Next case is a patient who presented to us with a history of epigastric discomfort and early satiety since 2 months. Upper GI endoscopy showed a sessile gastric polyp in the proximal stomach. Plan is to demonstrate polypectomy. Over to Dr. Rakesh.
Yeah, thank you, Anirudh. As you see here on the screen, I am in the NBI mode. I'll just go on to the white light. So this is a sessile gastric polyp, and this patient came with the history what Anirudh has narrated. I see there is a nice stalk here, but a little vascular, so the chance of bleed is more. So what I'm doing is I'm just going to inject at the base with methylene 2 and adrenaline and make the stalk a little bit edematous, and then for that I'll just show on NBA mode if we can see any pit pattern irregularity in this, as you see here. So this is how it looks, and it looks more like a benign polyp to me on the NBI mode, but nevertheless we'll send it for the histopathology. So what I'm doing is, first in these kind of polyps, important is the safety assessment of what to use and how to go about. It is a very juicy polyp for that matter, but only thing is that safety is important. When you cut, you should not end up having a bleed or any other complication. Can you use some Musco? So now what I'll do is I'll just inject the base with 2 and adrenaline mix, as you see here, nicely propped up. So now what I'll do is I am in a retroverted position, and the advantage of using this cap is the vision is better and you'll have a control on your accessories. So now open the snake. I am using a snare master, and as you see here, I'll slowly get onto the base of the polyp, and I'll make sure that I'm in a good position, also in a controlled position. So now I'll just coagulate first so that I'll have double assurance of not to bleed. Yeah, you see here it's a very vascular and fragile polyp, so it's already cut half through. I'll just make a small cut. Again, to coagulation. I think it's detached from it. Yeah, you see here. So the base is clean and there's no much blood. What I'll do is I'll now retrieve the polyp with a rod basket. And so the importance of this is, as I told you, you have to assess before you do. The procedure per se is very simple, but only thing is the little steps of endurance you have to have before doing these kind of cases. It's just only to document or demonstrate and recap the basics of polypectomy. Okay, so now I come out, the end of my procedure.
Rod basket.
Yeah, we use the rod basket.
Thank you, Rakesh, for that very neat case. What we'll do is we'll go to Mohan's room because he's progressed further before next procedure.
So you can see now, we can see the small bowel deep now. We are just trying to, so these are some of the problems here that, sometimes the progression is not very fast. So we have to keep on. I'm just changing the position of the patient from left lateral to supine and then supine. And the importance of, if there is, you don't see such progression very fast, you have to give a lot of abdominal pressure. And try to see that the over tube engages the small bowel well. So we'll ask our anesthesiologist to help us out in abdominal massage or pressure, and then soon we'll see how it is progressing. You can see now we are getting inside very gradually. Initial period, it happens post ligament of Treats also, and then once it engages, it's a patience. And if can somebody show my hands how I'm withdrawing and pushing the scope, just trying for the screws of the over tube to engage in the small bowel. And meanwhile, what I'm trying to is deflating and pushing with the abdomen. So many maneuvers you have to do. Keep on pushing. Yes, that's what I said. The 60% of van enteroscopy is 30% from oral, from mouth to cecum, while another 30% what we do is, suppose I'm not able to go beyond this point, I will put a tattoo over there or a clip over there, and then come back with the retrograde route and try to reach that tattoo. So if you do that, and that bidirectionally, you can reach to the that means you have completely examined the intestine. So you can do a retrograde enteroscopy very easily with this scope. In fact, sometimes very difficult colonoscopy also can be done with this. When there are a lot of loops, it allows us to deflate or to maneuver those loops, pleat the colon, the sigmoid colon onto the scope very, very well. So in Sri Lanka, if I ask you, we have done many workshops on single balloon. What is the best? What are the most commonly used modality there for interrogating the small intestine?
We use double balloon as well as single balloon enteroscopy.
Okay.
I think both are used similarly.
So this is the new scope which is which has been recently been introduced by Olympus, and it is an modification of the manual spiral which was invented by Paul Ackerman, where they use a manual rotation of the over tube to facilitate the deep enteroscopy. Olympus has bought that technology and modified it and converted into a motorized spiral. So gradually we are learning it, but also there are some challenges as is happening in this case. If you can show the fluoroscopy, please. See that we have gone into the quite deep, but still because of some resistance, the progression is not up till to the mark, but we should not give up. We should try many maneuvers. One of them is to turning the patient to supine. Can you turn the patient to supine? And then what we do is we give pressure at different sides. So now you can see again we have gone some depth again. Okay. Can you show the fluoro screen, please? So there is a kink over there. You can see this kink is we have to negotiate that kink. The tip of the overtube, tip of the scope is in U shape, and that is the only drawback of this scope, that in such situation usually the overtube senses the resistance too much and that it does not progress. And that for that we are just trying to push the abdominal wall in different places to reduce that angle, because in pharynx, if it stops at two places. One in pharynx. For pharyngeal resistance, you can extend the neck, you can deflate the endotracheal cuff, and then the resistance is gone. But at the ligament of Treats, sometimes the whole overtube has to travel through that acute angle, and there is very less chances for an operator to reduce that angle. We can reduce it by changing the positions, which we are doing, but sometimes it is very difficult to do that. So we'll try to keep on negotiating this difficult angle here. Meanwhile, we can go to the different room and come back again. Any questions from the chairpersons or moderators who will be happy to answer those?
Do we have like Mohan? Mohan?
Yes?
Yeah. Do you have any like contraindication to go for this the mechanical one, the upper G endoscope, this one?
Your question is not very clear to me.
Yeah.
The contraindication.
Yeah.
So the contraindication scope. Yeah. So the contraindication are like normal endoscopy, the acute intestinal obstruction, perforations, but most important is unique to this procedure. I will say that if there is a large esophageal varices, large gastric varices, we should not do this procedure. And more importantly, sometimes what happens is those patients who are post-operative, they have adhesions into the abdominal wall, and they can have lot of kinking in the abdominal wall, and there we try to avoid this procedure. So post-operative, large esophageal varices, and many diseases, infiltrative diseases of esophagus like eosinophilic esophagitis, that will not allow the overtube to pass.
Thank you, normal saline. Mohan, thank you, Mohan. Thank you so much. We are ready with the other case in the next theatre.
Yes.
Anirudh will give you the details and then we'll go on to the demonstration of fund application.
This is a case of 55-year-old male who had undergone Nissen's fundoplication in 2012 for reflux symptoms. Now he has presented with recurrent symptoms of refluxes for past 4 years. Upper GI endoscopy was showing a lax LES, Hills grade 2. Esophageal manometry was done, which was normal, essentially with hypotensive LES. 24-hour ambulatory pH and impedance test showed esophageal acid exposure time of 6% with more than 80 refluxes with high DMST score. Patient is not willing to undergo revision surgical procedure. Plan is to demonstrate GERD-X. Over to Dr. Rakesh.
Yeah. Thank you. Yeah. I think this is going to be the last case of the session. So just another 5-10 minutes with us before we close off. This is a very interesting procedure because we are treating endoscopically a failed surgical procedure. I think this is very important that endoscopists can do that now. Of course, Rakesh and Asif are here. They're experts for this and they'll quickly demonstrate the procedure before we leave.
Thank you, sir. So as narrated by Anirudh, so what I just started the procedure. So there is an inbuilt guide wire which comes with GERD-X device. So this is a metallic guide wire like how we use in the Savary-Giller dilation. So I am mounting the guide wire inside the up to the duodenum and then taking out the routine upper GI scope. So can you concentrate on the wire here? So this is a metallic wire on which I will railroad the device. And I haven't shown you the endoscopic view because he's got already a fundoplication earlier. There is a wrap which is being seen. So what I'm going to do in GERD-X is a gastrogastric fundoplication, unlike a gastroesophageal fundoplication. So if you see, you can show this. If you see the device externally, this is how the GERD-X device looks. I think many of the people in Sri Lanka are familiar of this because we have done a lot of workshops there. So this is a device which has got a handle with a shaft, and I'll show you how it works. Let me first do the first step of mounting the device. Can you just turn the device? So you can show me my hand, the hand movements. I am putting this metallic guide wire through the device. And then this device will be railroaded onto this metallic guide wire. You can show them my hand movements. So I am going to go through the channel which is there in this device. As you see, so now I'll make the device perpendicular to the patient's mouth. The patient is intubated in a supine position. And can you show them how it is going through? I'll put some silicone gel here for smooth lubrication and intubation of the device. Yeah. So now Dr. Santosh will assist me by extending the neck so that I can easily pass the device. And on the fluoroscopy, it will be a guide for me to see how the device is going smoothly. As you see here, it has crossed the esophagus and then beyond the GE junction in the stomach shadow. So now the device is inside the stomach. Yeah, you please remove the wire. So Asif is with me, who will assist me as a third eye. So what I'm going to do is, this device has got a channel through which you can pass a Olympus pediatric scope. And a couple of things on the device which I want to show is, there are fire mode, close mode and open mode, and also a helix to grab the tissue. So what Srinivas is doing is, he is putting in a sphygmomanometer cuff that is basically to inflate the stomach. And as you see here, Asif is going through the channel with his pediatric scope, and then once he goes inside, then he will show me the stomach, how it looks after inflation, and then with the pediatric scope, I'll retroflex my GERD-X device and then go to the GE junction. So unlike a normal GE junction, this patient has got a little bit of abnormal anatomy because he already had a fundoplication. As you see here, can you show me the tip of the device, Asif? No, just pull back. Yeah. See, so now along with Asif, I will also retroflex. And this, unlike a routine naive case of fundoplication, this is a little bit altered anatomy. So probably because he already has a wrap here, which you can see on the screen. So mostly we might require only a single suture. Typically we deploy 2 sutures because we take people who have a HILS 1 or 2 criteria grade on GE junction. So what I'm doing is I will just lock my device, and then I will take the helix out, grab the tissue. Yeah, take it inside. Now Srinivas will lock the helix, and then I will go to the close mode.
The endoscopic image.
Yeah, endoscopic image, please. Satya, endoscopic image, please. Okay, so as you see here, the G junction is already tight. At 9 or 8 o'clock, you can see there is a fold already there. So they have done a esophagogastric fundoplication. So what I'm going to do now is the gastrogastric one, because I got a good amount of tissue, I'll just close this class and then see. See, now the G junction is perfectly tight. So once I am in the close mode and the class have caught the tissue, I'll go to the fire mode and then just do a twice press of this lever so that the sutures are deployed. Now I go back to the open mode, then take the helix inside my device, and then I'll open the class and show you how nicely the G junction is completely wrapped up. Okay, you see? So this is after deploying the first suture. Okay, so we can, if you have time, then we can show with the endoscope, or else we'll just come back.
Thank you, Rakesh. I think that was an excellent demonstration. We are coming to the end of our time. I think we are given 3 hours and we finished over 12 cases, which have been all very interesting cases. I hope all the gastroenterologists and the surgeons in Sri Lanka enjoyed this show. Certainly, we at AIG in Hyderabad enjoyed doing it for you. And we'd like to thank you again for giving us this opportunity to show various procedures, which are from basic to very high end. And I hope that someday we can also physically be there, or you can be physically here to observe and do some of this. Again, thank you very much on behalf of the Asian Institute of Gastroenterology, Hyderabad, India, to all the Sri Lankan.
So, we have tried to show few interesting cases here. So that is the end of our live workshop for today's Bangladesh masterclass program. I hope all the cases, whatever we have shown, would be important and practically those people who watch this program would be having some benefit out of. We have tried to show few interesting cases here. Important and practically those people want important and practically important and practically there is some audio disturbance. Yeah, now we can hear you very clearly. Yeah, so that is the end of.
Unmute yourself.
Yeah, it's unmute here. Can you hear me now?
Yeah, we can hear you.
Yeah. So this is the end of our live transmission for today's master class. I hope you all had a good interaction. Yeah, now we can watch all the cases very clearly. Thank you.
Yes. Thank you very much, AIG team, for your live demonstration and excellent test.
Thank you.
Now I would like to request Professor Fazul Karim.
Yeah. So this is the end of our live transmission for today's
The Department of
master class.
Hepatology, Solomon
I hope
Medical
you all
College,
had
for his remark. As Professor Chittaranjan Devnath
now
sir
we can watch
just
all the
joined in
cases very clearly.
and
Thank you.
he will not be able. Thank you very much, AIG team, for your live demonstration and excellent test.
Thank you, sir. For very nice presentation. We have learned from basic to advanced in both cases like NFLD, where a gastric intergastric balloon can be placed. It's a new concept.